Medicine and Rehabilitation at AIMS, New Delhi. Sir's interest areas are neuromuscular rehabilitation, low back pain, cardiac and geriatric rehabilitation. Sir, over to you. You can share your slides, sir.
Good afternoon, everyone.
Good afternoon, sir. Sir, your slides is not in presentation mode, sir.
I am sharing the slide and it is now on my desktop. It is visible as the full screen view. View slide, yeah. Is it?
Just click the F5, sir.
F5. Okay, I have done that.
Sir, you might have to click, double click the slides.
Any change there?
Yes, sir.
Is it visible?
Yes, sir, it's visible. Now you can, sir, do it in slideshow mode.
Yeah.
And share that screen, sir.
Yes. Can you see that?
Sir, just decrease the size of the slides.
Can you see now? Is it fitting into the frame? Yes or no?
Custom slideshow, sir.
Any better?
The resume slideshow on the screen. Slideshow. Not on the Zoom, but on the PowerPoint only. Yeah, you are at right place. No, sir, not. Just go slide upside.
Start slideshow. This is where I am from beginning. Custom slideshow.
Click on this.
Which one? The cursor is now on custom slideshow.
Custom or for beginning, anywhere.
From beginning. I have done the from the beginning click. Is it visible?
Stop the screen sharing and then share the whole screen.
Sir, you can stop the screen sharing and then share the whole screen, sir. Yes, sir, it's now working, sir.
Okay, thank you. These are the challenges of the technology, although younger people are far more conversant. So good afternoon and thank you everyone, and especially Dr. Anand Krishnan and Professor J.S. Thakur. It is always a pleasure to connect with you and other participants during this international course. I will be covering the topic that was assigned to me, mainstreaming rehabilitation. Now, there have been some recent global initiatives, and you may be aware of some of those, or maybe all of those, but my experience has been that people are less aware about the initiatives in the rehabilitation scenario compared to other healthcare domains such as communicable diseases or the leading non-communicable diseases. So one of the important initiatives globally was United Nations Convention on Rights of Persons with Disabilities. This happened in the year 2006, and it was ratified in 2007.
You're not audible. Uh, can you hear us? It seems there's a network issue. Let's wait for some time and then we can continue.
Hello.
The slides are, you have to go to the start from beginning. And double click on that. Double click on any of the slides.
I've done that. Any change?
No, sir. Double click on the slide.
The slide moves forward when I double click that.
Yeah, yes, sir. From the beginning.
Is it visible now?
It's in the same place. No change, sir. Can you stop the sharing and share again?
I've stopped the sharing. Now I'm sharing screen again. Let us hope I succeed.
Yes, sir. Perfect.
Okay, thank you.
Over to you, sir. Thank you.
Thank you. So as I was telling that World Report on Disability was a very important event, joint publication of WHO and World Bank. And after that also there have been a couple of initiatives which have a direct and significant impact on the rehabilitation. And one of these are World Health Organization's Priority Assistive Products List and Rehabilitation 2030 Call for Action. And you are aware that Sustainable Development Goals are very important. They are the ones which replace the Millennium Development Goals. And Sustainable Development Goal 3 has a direct bearing on the health and well-being. And now in the recent documents, it is clearly stated that rehabilitation is a priority area for action for the World Health Organization, because it is realized that rehabilitation, the contribution is not confined to persons with disabilities only. It is a very important part of the overall development process. Now, this is the scenario from the United Nations Convention in the year 2006, where more than 140 countries participated, and India, being a signatory, was bound to implement its provisions and various sections. Prior to this, in the year 1995, there was Persons with Disabilities, Equal Opportunities, Protection of Rights and Full Participation Act, 1995. At that time, it was a significant move forward, but in keeping with the global trends and changes, the UNCRPD was more rights-based, and accordingly, the laws in different countries also needed to be aligned with that. So World Health Organization has always been at the forefront of spearheading the rehabilitation policies and programs throughout the world. And India is not aloof to all these things. So this is the World Report on Disability, joint publication of WHO and World Bank, 2011. It is a voluminous document compilation and a very rich source of information on the disability and rehabilitation. So anybody who is interested, my suggestion and request is to please have a look at this. You will definitely find useful information in this document. And this is a priority assistive products list, because rehabilitation is a field which is different from many other fields. This is different in the sense that various persons with different impairments and functional limitations require different assistive products for their integration back into the mainstream and for their facilitation of performance of different activities. And in keeping with the essential medicines list, WHO thought of making a list of essential assistive products so that they can be made available to a much larger number of people who need them. So this was the outcome of that deliberation and discussion, priority assistive products list. And these are basically with the purpose of improving access to assistive technology for everyone and everywhere. Many of these products are low cost, but reasonably high impact products. Now, when the title of my talk says mainstreaming rehabilitation, we need to be clear about what is the meaning of mainstreaming. One of the definitions or statements is that mainstreaming is about building disability into existing agendas, frameworks, and processes. Mainstreaming is a method to promote inclusion and to address the barriers that exclude persons with disability from full and equal participation in society. There are many programs, policies throughout the world, not just recently, but for a long time. But in many of these programs, persons with disabilities have not been included, or if included, not adequately included. And basically, what are the needs of persons with disabilities? These are the same as that of a person without disability. In the childhood age group, it is the education. In adult age group, it is a livelihood. And then there is social integration and looking after the healthcare needs. And all these with the ultimate purpose of ensuring empowerment of the individual. And persons with disabilities also are very important sections of our society. And in fact, some people say they are a silent majority. According to the World Report on Disability, about 15% of the population is having one or the other kind of disability. And no nation can afford to ignore this sizable proportion. Although official figures in India indicate very low prevalence or magnitude of the problem, which is about 2.2% or something, but many experts know and feel that this is a significant underestimate of the problem. Now, very important question to be addressed is that why mainstreaming rehabilitation? Globally, 1 in 3 people are living with a health condition that can benefit from rehabilitation. These needs are spread across the lifespan, from childhood, people with congenital or intellectual impairments, young adults with physical limitations resulting from unintentional and war-related injuries, older people experiencing chronic diseases. Many of these are non-communicable diseases such as stroke, cardiovascular disease, diabetes, chronic lung disease, chronic kidney disease, or people with difficulties associated with aging per se. And globally, the proportion of people with aging is increasing, and so are the limitations as a result of increasing age. Now, these rehabilitation needs will only grow in the coming years as population continues to age, and number of people living with chronic disease continues to increase throughout the world. Many countries are not equipped to respond to the existing rehabilitation needs, let alone the forecast increase that is arising from health and demographic trends. Rehabilitation is often not prioritized in countries and continues to be under-resourced. As a result, countless individuals do not have access to rehabilitation services, leading to an exacerbation of their condition, further complications, and lifelong adverse consequences. In some low and middle income countries, more than 50% of people do not receive the rehabilitation services they require. And this is in fact true about our own country also, India. So all this thing makes rehabilitation to be part of the mainstream agenda in the healthcare programs and schemes. In the year 2017, in recognition of the growing global rehabilitation needs, underdeveloped rehabilitation services, and significant potential for unmet rehabilitation needs to increase in future, the World Health Organization member states, development partners, and civil society came together to launch the Rehabilitation 2030 initiative. Now, this was a very important initiative and it gave a call for action. And this is the photograph from that particular event in February 2017. This was subsequently followed by another global event after about 2.5 years. This was in July 2019. This was the second Global Rehabilitation 2030 meeting. They assessed what has been the progress since the last meeting and what is the way forward. Now, COVID-19 pandemic has been a global event. It has impacted all those programs and things which were going on, and it has posed new challenges. But like every challenge, there are some opportunities also. COVID-19 pandemic has brought into focus the important role which rehabilitation services can play in management of COVID-related consequences, as well as other chronic conditions where there are functional limitations and disabilities. The role of pulmonary rehabilitation has been amply demonstrated and brought into focus during the COVID-19 pandemic. And as the new variants came, the severity changed, the clinical picture changed. Now people with less pulmonary involvement are manifesting with neuromuscular disorders, with rheumatological problems and functional limitations. So a responsive and responsible health system should have or plan to have human resources, infrastructure, protocols, standard operating protocols, and finances to respond to this demand fully in a sustainable manner, as these demands are eternal for all times to come for an efficient and responsive health system in any country. It is felt by some experts that the rehabilitation services are haphazardly delivered within the present Indian health system, as norms, standards, delivery model, infrastructure, including essential human resource, quality control, etc., for these services are yet not well defined. Some attempts are made in recent National Medical Commission notification for new medical colleges and its associated hospitals. Some attempts were made earlier in the IPHS, which were notified in 2012 by the Ministry of Health and Family Welfare, and Clinical Establishment Act 2010 and its subsequent amendments, which tried to lay down standards at the primary and secondary healthcare services, as well as they defined the minimum standards for a physical medicine and rehabilitation service establishment necessary for its registration. The recent national initiatives include Accessible India campaign in 2015, Rights of Persons with Disabilities Act 2016, Pradhan Mantri Jan Arogya Yojana or Ayushman Bharat scheme, Clinical Establishment Act 2010, I have already said that. The National Health Policy Document 2017 mentioned rehabilitation and palliative care besides the early intervention, diagnosis and treatment. A unique disability ID scheme has been a new initiative of this government and National Medical Commission, which has for the first time mentioned that physical medicine and rehabilitation should be an essential department in a new medical college. Earlier, it was under the category of optional along with radiotherapy. So these are some of the new initiatives, and this is the Gazette of India notification on the Rights of Persons with Disabilities Act 2016. And as in the beginning itself, it has stated that it is an act to give effect to the United Nations Convention on the Rights of Persons with Disabilities and for matters connected therewith or incidental thereto. And this is very important piece of legislation, and this has a direct impact on the rehabilitation and disability scenario in the country. And persons from various disciplines are expected to know about this law. It is now more than 5 years since this law was passed by the Parliament of India. Now, this law defines clearly what is the meaning of person with disability. It means a person with long-term physical, mental, intellectual, or sensory impairment, which in interaction with barriers hinders his or her full and effective participation in society equally with others. It is an important law because it also clearly defines a person with benchmark disability, which means a person with not less than 40% of a specified disability, where specified disability has not been defined in measurable terms, and includes a person with disability where specified disability has been defined in measurable terms as certified by the certifying authority. Now, most of the benefits after participation into various programs and schemes of various state and central government, one is entitled to avail the benefits if a person belongs to the category of person with benchmark disability, and person has to attach a duly produced document by a designated medical board. So many a times people ask, what is rehabilitation? This is also important to understand. And this Act, Rights of Persons with Disabilities Act, defines under one of its sections, rehabilitation refers to a process aimed at enabling persons with disabilities to attain and maintain optimal physical, sensory, intellectual, psychological levels of functioning in different environments and different social situations. And there is a schedule part of this Act which lists various specified disabilities. In this Act, 21 conditions have been mentioned as various disabling conditions, and these are specified disabilities. They are under different categories. Under physical disability, there are some such as locomotor disability. Then it is very important to understand that the United Nations Convention on Rights of Persons with Disabilities also mentions about mainstreaming disability. If you look at the bottom of this slide, it says, emphasizing the importance of mainstreaming disability issues as an integral part of relevant strategies of sustainable development. A society or a nation cannot have development in its real sense if it ignores or leaves behind a significant section of society, which includes persons with disabilities. So this is the list of specified disabilities. As I have already told, there are 21 of these. Physical disability, which includes locomotor disability, visual disability, then intellectual disability, speech and hearing, etc. So, and if a person has more than one of these together in the same time, then it is a case of multiple disabilities. And gradually it is observed that the number of people with multiple disabilities is also increasing. This is the full list in another format presented here. For the first time, they have included people with chronic neurological conditions, people with blood disorders, acid attack victims, etc. Now, rehabilitation has to be understood along with the WHO's model of disablement, which is the ICF, International Classification of Functioning, Disability and Health. And this is the pictorial depiction of interaction among different things: health condition on one side, body functions, activities, and participation. This has replaced the earlier International Classification of Impairments, Disabilities, and Handicap, which was there in 1980. And this is the new model, which was proposed in 2001. This is called biopsychosocial model of disablement also. Now, the principles of rehabilitation are very simple, as they are of any good medical discipline. Multidisciplinary team approach, early intervention, providing relief of symptoms, ensuring return of function, attempting continuum of care, and improving the quality of life. But there are different approaches to achieve this. Commonly, what we see around us is the institution-based rehabilitation. But it has been studied and well documented that only a small proportion of the total persons in need of rehabilitation are able to avail their benefits. Because majority of people are living in the rural areas in India, where institutions are far away. They are either non-existent. Then there is another approach also to rehabilitation, which is called the outreach rehabilitation, where people from the institutions visit the community on a periodic basis and try to assess and meet the needs of persons with disabilities. A camp approach or the approach through a mobile unit is a very common example of outreach rehabilitation approach. And community-based rehabilitation is the approach of rehabilitation which is located within the community. And by participation of people within the community, almost 70% of the needs of persons with disabilities can be met. And only 30% of people require referral to higher centers. Now, what is very important to understand, if you people can understand during my lecture, one concept, I would like to say that please realize rehabilitation is not equal to physiotherapy. Many people have this misconception because they see more physiotherapists around them or in the hospitals. Rehabilitation departments are increasing in number in different medical institutions, but still every medical college in the country does not have an independent department of rehabilitation. So rehabilitation is much more than physiotherapy. Physiotherapy is no doubt an important allied health medical discipline, as is occupational therapy, as is speech therapy, and several others. There is a national initiative of allied health sciences by the Government of India, which has identified more than 35 health professions, which are neither nurses nor doctors. So these are under the group allied health sciences. And there is a movement in the direction of creating a central council also for them. And physiotherapy is not equal to diathermy. So therefore, rehabilitation is not equal to diathermy. Rehabilitation is much more than all these. Now, you are all much more aware about what is the number of districts, sub-districts, and villages. So I will skip these things. But what is important to realize is that India is very vast, and most of the places people are not getting the services which they need in terms of the rehabilitation services requirements. Even basic services such as home-based exercise or simple mobility aids like walking sticks, or sometimes if required wheelchairs, these are not easily available to almost 75% of people in the rural areas where they are there. And even if they are lucky to get it once, there are no provisions for their repairs or replacements. During the COVID-19 pandemic, one has realized that it is not necessary that people should come to the institutions. Tele-rehabilitation consultations have been found very useful, and they have also ensured the connect, because people with disabilities due to lockdown and several other factors could not avail the services. So in order to ensure that the effect of disruption of the care and services is minimized, tele-rehabilitation services have been found to be very useful, and they are effective even now. 2 years ago, National Medical Commission made physical medicine and rehabilitation essential department in a new medical college. So this is an important step, and I am hopeful that in the years to come, positive changes will be there. And as more and more medical institutions have departments, more and more people will be trained. And once they are trained, they will be moving out in the society. Among the persons with disabilities also, there are certain groups which are more vulnerable. And these include women with disabilities, children with disabilities, elderly persons with disabilities, and persons with multiple disabilities. Now, we all know that persons with disabilities have various other needs, and not just healthcare needs. And transportation facility is an important need of people with disabilities. So this is a photograph showing that this bus is suitably modified for a person who is on a wheelchair so that he can use the public transport. The bus is required to have low floor, wide doors. It should be safe, eco-friendly, non-polluting, and comfortable, with grab bars and ramps. But very few buses you will see in your real life which have all these provisions. What is important is that it is possible, it is very much needed, but it lacks the priority attention of the state administration. There are several key components of operationalization of health and welfare centers. And there is a lot of attention and movement in this direction also. And the range of services has been expanded, and now it includes 12 types of services. And what is important to understand is that management of communicable diseases, management of common non-communicable diseases also. Now, you cannot manage them comprehensively and in a long term by ignoring rehabilitation service component in that. Elderly people require a lot of rehabilitative care. So it is very important that rehabilitation services are introduced into the health and welfare centers, and they are strengthened further. The target by the end of this year is to create 1.5 lakh health and welfare centers. There is a significant movement in that direction, but unfortunately the COVID-19 pandemic also disrupted and slowed down the progress in this very important area. Now, health and welfare centers, the Ayushman Bharat, their web portal clearly mentions that Ayushman Bharat is an attempt to move from a selective approach to healthcare to deliver comprehensive healthcare, which is spanning preventive, promotive, curative, rehabilitative, and palliative care. So I wish that rehabilitative component also deserves and gets due importance as is given to preventive, promotive, and curative components. And I have already shared with you that this is the target by the end of 2022 to have 1.5 lakh health and welfare wellness centers. But there are several challenges, although India has made a lot of progress since independence in 1947 and since the present government in the year 2014. But there are challenges in terms of training of rehabilitation service providers, especially physical medicine and rehabilitation people. There is a challenge of need versus the supply. The need is far more than the supply at present. There is early referral to rehabilitation services, which is lacking at present, because greater the delay in availing the rehabilitation services, greater is the suffering and cost. Sometimes it is seen that rehabilitation services are provided in bits and pieces, and there is lack of continuum of care, or rehabilitation care is not comprehensive enough. You may provide mobility aid to someone, but ignore other components. Cost effectiveness of rehabilitation intervention has been amply demonstrated in some studies. So this has to be realized, and this has to get due importance. And gradually the base or the body of evidence base for rehabilitation intervention is increasing rapidly. It is not an empirical thing. And what is required is allocation of adequate resources and monitoring and evaluation so that there is no wastage. Now, this is a very important challenge, the chicken and egg, because you don't have too many medical colleges which have independent departments of physical medicine and rehabilitation. So not enough number of people are being produced and trained. And if you open the new institutions, who will man them? So this has to be appreciated, and attempts have to go on both the areas. You have to produce much more and in a shorter duration. Of course, ensuring a certain minimum duration and quality control. The rehabilitation guide for action, which is an important component of rehabilitation 2030 plan for action. It is very sad to note that very few countries in the world have utilized the rehabilitation guide for action. And this is the map which is updated in September 2021. And unfortunately, India is missing from the countries that have utilized the rehabilitation guide for action. Last month, the Indian Association of Physical Medicine and Rehabilitation celebrated the golden jubilee of its formation. And there was an international conference held in Delhi in a hybrid mode. And I was the chairman of the organizing committee. And utilizing that event, I tried to reach people, the common people, through media and press conferences, that there is a great need for rehabilitation services. Pandemic has highlighted the importance of rehabilitation services, and rehabilitation services are required in great number and measure by non-communicable disease patients also. So I hope the message reaches. And with this, I will like to conclude, and I will request you all also to please realize the importance of rehabilitation services and become a partner in this. Together, we can achieve much more than either of us is able to do alone. Thank you so much.
Thank you, sir. Are there any questions?
Good afternoon, sir. Thank you for your nice presentation. I
Thank you.
have a small doubt.
Yes, sir.
Hello.
Yes, sir. Please introduce yourself and ask the question.
Sir, I am Lalit, State Program Manager NCD from Government of Odisha.
Okay, welcome.
Sir, we are implementing that NPPCD program and NPSC program in the statewide, but
Yeah.
is in RBSK unit we are screening the a patient from 0 to 18 years,
Yeah.
and we are providing the hearing aids and the goggles to the children and the infant.
Yeah.
But after 18 to the senior citizens and those who are needed the hearing aids and the goggles, but that is not supplied.
Yeah.
That is the part of the SSCPD department.
Sure.
So it is a very gap between a health and an SSCPD department for coordination.
Yes.
Is there any solution, sir? How can we implement?
Thank you for highlighting this gap. There are many other areas also in which there are gaps. So one of the first steps in bridging the gaps is their identification, and then writing to the authorities. Because I will share with you one more example. There is a Ministry of Social Justice and Empowerment. It had this scheme of ADIP, assistive devices for persons with disabilities. That also caters to a very small proportion of people with disabilities with limited aids and appliances. So I have written officially to them to expand the ambit of this thing. But every time the issue is that India is a resource-starved country. The resources are limited. The people who need to get the benefit of various services and products is much more. And so far, the private sector has not partnered with the government machinery in trying to ensure that the assistive products reach the people who actually need them. One of the experts once remarked jokingly that, sir, if you calculate the amount of money which is spent on elections in India, the amount is so much that if it is pooled together, we can meet the healthcare needs of a much larger number of population, and the suffering will be much less. But that is the opening up of another debate. But I agree with your concern. There is an urgent need to bridge the gap and try to ensure that services reach continuously throughout the life cycle, not they are abruptly stopped at a particular age. Thank you. One has to write to the concerned ministries and press upon them that please allocate more resources.
Good afternoon, sir. One more question. I am Dr. Manoj from Faridabad.
Yeah.
That you have told that, sir, benchmark disability, but that UDID certificate is not being generated below the 40% of
Yes, sir.
disability. So
Yes.
people get frustrated if like disability is below 40%. They said why certificates are not being generated on UDID.
This is a decision by the Department of Empowerment of Persons with Disabilities, because they feel that there is a large number of people who have 40% and above disability. Let us try and meet their need first. And as it is, they feel that a person who has disability below 40% is generally not going to get any benefit out of a various schemes of the government. So priority is to people who are having a disability certificate, which says that the person has this kind of disability is permanent, and it is 40% or above. So the UDID cards are being generated for them. Later on, if there is a policy decision that we can spread it to people who have less than 40% disability also, and if there are certain concessions and benefits to be granted to them also, then there may be a change. But right now, you are absolutely right in your observation. This may be frustrating to some people, but that is their policy at present, because there is a very large number of Indian population which is still not getting the UDID cards, because the India is very large and the process is on. There was a Gazette notification in this regard in May 2021 that from 1st of June 2021, all these things will be through the UDID portal. But yet there are many people who are to receive the training, and there are many people who have the training, but they don't have the resources in terms of computer and internet facility, etc. So it is a challenge. It is a work in progress, but I'm sure that 5 years down the line, the scenario will be much better, much improved. Thank you.
Are there any more questions? Sir, okay, thank you, sir.
I would like to end again by thanking Dr. Anand Krishnan and all of you. Thank you. Have a great day.
Next, we will have presentation by Dr. Mohan.
So good afternoon, everyone. Enough information overload is there already. So I will try to keep myself as much brief as possible, because your group activity is also not getting enough time. So this session is about monitoring and evaluation, and you all know that whatever we do, ultimately, if it's not measured and it's not improved, then it's not done ultimately. So for the systems, health system improvement, its monitoring and evaluation is a prerequisite, or it's an integral component of any healthcare program. So in this session, we will largely discuss three components. One is identify and use contextual indicators. Okay, so am I audible now? Okay, thank you. So in this session, we will discuss three components largely. One is identify and use contextual indicators and understand relevant data sources. One component of presentation is apply cohort monitoring approach for the performance measures, and use of monitoring and evaluation framework to build MIS, management information systems. So you all know that what is monitoring. I won't go into the detail, but important thing is done that what gets measured gets done. So that is important. But monitoring simply just track the activities and identify the deviations from the projected your plan or your objectives. You have decided activities, whether all activities are on the track. So monitoring answers those questions. And simply we can say that counting and tracking the processes and activities events are known as monitoring, and it answers the questions like what is happening, where, when, how much, how many. These kind of the questions are answered. And for that, our monitoring evaluation system have a set of targets and indicators to address those targets and timelines of those indicators for achievement. So why we talk about the monitoring, we have discussed already that it is an integral part of the healthcare systems, and it provides us information about the quality of care, effectiveness of the treatments or the program performance. It helps us in identifying the healthcare facilities which are having lower performance, so that timely interventions can be taken. It also provides information about your plan of action, so that what has been being accomplished and not accomplished, it can provide information. It also provides some advocacy material to the program managers, so that they can identify that those activities are slow in the implementation. They can ask for the more resources if needed, or if are on the track, then they can decide its implementation to newer strategic and demographic geographic areas. So any health monitoring evaluation program should ideally address inputs, processes, outputs, outcome, and impact indicators. So some indicators we need data at the population or community level, patient level. For some indicators we need data of the program performance. So it's all about the large basic components of the monitoring and evaluation system. So there is a global monitoring framework that provides 9 key voluntary targets. Those countries need to decide those the performance to measure, and these 9 voluntary targets having 25 indicators. And there is some criteria that the baseline has to be some particular year, like 2010. For some targets it is 2010, for some target it is 2015. So based on that, they can decide that where they want to reach and where they want to reach, and what kind of the strategies and activities are needed. So there is some change in this after 2021 update, but there is not major change in the outcomes or the indicators, just targets have been slightly changed. So largely this monitoring framework, you see it talks about outcomes and impacts, but the performance, now we are talking about high performance healthcare systems, and the performance measures are also important. So where we also need to talk about performance related indicators like availability and competency of the health human resources which are available. You need to talk about the patient satisfaction, refill rates, referral loop, control rate, hypertension control rate, diabetes control rates. Some of you already know, those who are working on ICHI, about the relevance of cohort monitoring and control rates, and community level control and community level control coverage rates, and cost saving for the patient is also important area which need to be addressed. So this is just snapshot or just a sample that how performance related indicators can be designed and taken into the consideration. For example, team based care. So team based care, you can find that some key human resources are not available. So it could be one indicator that some posts are vacant, and those human resources are available, whether they are appropriately trained or there is a need of the skill building or capacity building is required. So that can be measured by provision of the training. Process, we should also need to talk about the improved workflow. So for example, you have designed the modified workflow according to needs of your facilities, but whether it is being implemented, prescribed the steps are being implemented. So simple checklist using supervision can be utilized for that, and this can measure patient experience or patient satisfaction. Like team-based care, through team-based care monitoring, you can understand the status of program implementation. Similarly, we can talk about continuity of care. For example, health facilities with the stock outs, status of the refill rates. So this can provide you some insights about forecasting of the medicines and implementation of the supply chain management, improvement of the supply chain management, and outcome impact data related to patients and community are also important. So control rates and control coverage rates are important indicators. Patient visit records and population information can provide you these indicators. And these ultimately provides you the informations on the overall quality of the clinical services, and it also help you to identify poor performing facilities, comparing the facilities, and ultimately coverage of services in the healthcare facilities. So to measure the control rates, we need to understand the cohort monitoring approach in the NCD care. We have had enough talks and discussions, and this concept already have come into discussion. So it's important to understand that why it is needed, that NCDs are lifelong and complications of the NCDs are due to cumulative experience through the life course. So complications are not due to not taking medicine for one month, 2 months, or not it's like that, but it is a cumulative experience that what has been happened in the last years, maybe 1 year, 2 year, 10 year, whatever the disease duration in particular patient. And again, we also need to understand that there is a lot of drop in, drop out from the healthcare system regarding NCD patients when they are taking long-term treatment. So when we use the cohort monitoring approach, it also considers that. And this is simply track the program outcomes rather than snapshots of the services. So this is ability to provide all these information. So it allows health facilities to compare with each other, as well as you can also compare cohort to cohort, whether which cohort is performing in how. And it can also, but the point is that to have data on these indicators, we need to change our data compilation process, because largely our health management information systems, if we leave aside maternal and child health care, mostly data are collected and compiled in the cross-sectional manner, but it needs data to be managed in longitudinal manner. And ICHI is a classical example for that. They are measuring diabetes and in some places hypertension as well. So they use the quarterly indicators. You can also use, in some countries, 6 monthly indicators are also being used. Simply to understand, you can see from the picture that in 2020, one cohort has been recruited, or the patient has been registered in the first quarter, January to March cohort. So outcome would be measured what is happening to these patients when they have, all of them have completed at least 3 months of the treatment. So all of them have completed the quarter April to June. So outcome would be measured, or the control status would be measured in the end of the June. So this is a 3 monthly cohort, 3 to 6 monthly cohort. Similarly, 6 to 9 monthly cohort can also be used. Some countries are using that. In that case, minimum 6 months for all patients is required. So at the end of the September, outcome of these patients will be measured. So this is how it will provide that actually what is happening, those who are getting treatment to you, irrespective of simply those who are coming or reaching out to your facilities. In this way, those who are drop in or left out of the treatment will also be identified. So this is just snapshot of the performance of some states where it is being implemented. So if you can see Telangana, we have listened a good story from a program manager, Dr. Reddy, the day before yesterday. Telangana and Kerala, you can see they are the good performer. And this picture shows that the green bar showing that the percentage of the patients under treatment are under control. Then you can see yellow one, those are not under control, and red one, those are missing visits. So ultimately, the missing visits are also important. Those are not under control are also important. And you can see on the downside that in Maharashtra, Punjab, it's about 50% of the patients missing visits. So ultimately, it's difficult to comment on the quality of services, because control rates are about just 1/4 of the patients are under control. This data belong to 2019. This situation may have been improved if better implementation is there, but broader situation is like that. So after that, I'm coming on the third component of the presentation, that is supervision. That is, supervision is again important function of them related to the monitoring, and it provides information about the functioning of human resources as well as quality and quantity of the services. So you all of you, those who are in the service or job, are aware about the importance of the supervision, but it's not important. Just implementation of the supervision in appropriate manner is also important. So senior members of the team, service providers are expected to handhold all the providers at the grassroots level, junior members, and they also need to understand the problems accurately and need to handhold if they do not able to provide appropriate quality of the services, then they need to demonstrate them, they need to make them understand. So that is important. But we also all know that it is a weak and challenging component of NCD programs, all programs, but especially of NCD program, non-available because nowadays declining number of the field visits, lack of vehicles, lack of POL. These are some issues, and these issues may vary from place to place. So appropriate planning and budgeting is important key if you want to ensure effective supervision, and this has to be supported nowadays by, you can use virtual techniques, online applications as well. WhatsApps and other applications are also can help you to provide, at least to provide feedback, to see their skills, how they are performing. So you can also use these applications for observations or supervision as well. So ultimately, one is you have to have a schedule, you have to have a, when you have to have a schedule, then you also need to have a mechanism of feedback. So feedback loop is again most important component of the supervision. If there is not a good feedback loop, then this activity of the supervision would not provide the sufficient benefits which is required from them. There are some techniques supporting supervision, random verification, document review. Nowadays we provides more emphasis on the supportive supervision, because in the supportive supervision, feedback is an important component there. So feedback is important. You need to understand. I won't go into the detail how feedback can be provided. There are multiple ways of doing that. It can be written, verbal, but ultimate thing is that it has to be structured and it has to be a compulsory or necessary component of supervision activity. Now coming to the last component is the evaluation. Evaluation is simply difference between monitoring and evaluation is that monitoring try to identify the deviation of the identified or the activities, and evaluation is largely focused towards what you have achieved ultimately because of those activities. So it could be impact evaluation that can say that what changes have been occurred because of the program and what aspects of the program has contributed or attributed to the changes. Process evaluation can provide you information or the insights on what did implemented and what did not implemented. External evaluation is another way that is used to be independent and unbiased. So this could provide a better picture of what is going on. And rapid appraisal is another tool. So in-depth interviews or some small observations, small surveys can be used for the rapid appraisals. So that is also an important technique of the evaluation. So what are the challenges for effective monitoring and evaluation systems? So ultimately, we know that the understanding of the need and readiness of the HMIS system is important, and we need to invest sufficient time and money into it, but there is no clear understanding about it, so that ultimately it affects the effective monitoring and evaluation systems. Then again, lack of reliable systematic data on NCDs especially, that makes tracking of trends, impact of the interventions and evidence-based policy making more difficult. One important is that demand for ownership of such a system, that is a most basic requirement that is difficult to establish in the situation that we are facing. And ultimately, we know that lack of demand ultimately rooted in that we do not have a robust or good, strong evaluation culture or culture of the data use. So, and that comes from that our public sector are largely not performance oriented. So ultimately, because of that, this is quite challenging for us. So developing countries ultimately finding it difficult to do long-term strategic investment, and that is one important challenge in the sustainability of the good or robust monitoring and evaluation systems. So these are the steps of developing a monitoring and evaluation system. You can have an idea about that. So formulating outcome and goals, then that can be identified from existing monitoring framework, global monitoring frameworks, or the national policies. And you need to select the indicators for performance and for the global monitoring framework indicators. Baseline information is again important. Then specific target and timelines are also important. Need to design an information system, regular collecting data, and for the program managers, it is also important that when we talk about data collection, then it is important to understand that those who are collecting data need to understand the value of those data. So again, here point of the feedback, that those who are collecting data, feedback should reach to them. They need to understand that what mistakes are they are making, what good things are they making, and what change can be made because of their efforts. So if their efforts is valued, then probably they would be more motivated. And compilation, analysis, reporting, ultimately part of the feedback loop. So capacity of the analysis and reporting is again important component of this system, because ultimately if data is used for the action, then it's important. If data is not used for the actions or decision making, then it defeats the purpose of the entire activity. So use of them for the program management or program effectiveness is important. So the key messages are that monitoring and evaluation system is a critical component of the program plan, strategic planning, and the improvement in the health systems. And it answered the questions like where we are, how we are doing, how many, how much, or evaluation again talks about the effectiveness of the system. And it is composed of indicators related to input, process, output, outcome, and impact. And performance measures again are relevant, and people-centered care-related indicators need to be included in performance measures. And in countries like us are different challenges like lack of appreciations to its need, hesitation in invest timing and money in design and implementation, and finally poor use of output in the program management or program improvement is again important challenge. And nowadays role of virtual techniques need to be promoted, and it has to be utilized, and it should supplement the constant resources which are in our facilities. So this is all about. Thank you very much. Please feel free to ask any question.
Any question?
It seems it was very much clear. Thank you so much.
Thank you, sir. Anybody has not submitted the CME credit form? Submit it, because it has to be signed also. Any TA form that is pending to be submitted?